And thanks, everybody, for your attention. It's a pleasure to be here. So we're going to talk about the eye, and I'm going to talk about wet AMD, and your grandparents, maybe unfortunately some of your parents may have developed this already. We're dealing with the back of the eye. So if you think of the eye as a camera, obviously light goes in it, and like in a normal camera where you have film to see, there's a film at the back of the eye called the retina, which is what we're talking about. If you have a problem with a film in the camera or a problem with the retina, in a similar way, you won't see very well, and depending on where that disease is, you can either be blind or lose vision. Okay, so we're dealing with the retina, which is the nerves at the back of the eye. Now, fibrosis in the eye, in the retina, which is what I'm talking about here, is perhaps a little different to lung fibrosis and kidney fibrosis in that we are dealing with a neural tissue. And that means the mechanisms will have some similarities, but there will also be some differences as well because of the cell types that are involved. And that's something I want to stress right at the outset. We are not talking about necessarily exactly the same types of mechanisms, although there will be some overlap. When we talk about fibrosis of the eye, what we're really talking about is scarring of the retina. If the retina, which is a very transparent neural tissue, it's filled up with lots of neurons that allow us to see, if that becomes white and opaque, then the cells in the retina can't pick up the light and therefore you cannot see. So fibrosis is basically any condition in the retina that leads to scarring. And of course, there are a number of different types of diseases that can do this, aside from trauma. I'd like you to think about fibrosis as really characteristic of two major diseases, and those are diseases that involve the retinal vasculature, and these would be age-related macular degeneration and diabetic retinopathy, end-stage diabetic retinopathy. And the other types of diseases are to do with retinal detachment, where you get scarring because of the disease process where the retina separates from the back of the eye. It has to be placed back on the eye, and as part of that process, part of that surgery, you can get a scarring develop just like you would with other types of surgery. I'm going to focus on the retinal vascular diseases because this is my area. I'm an expert in the retina and the neurons of the retina and in those two diseases, so I'm going to talk about that. And I should also point out, if we understand the mechanisms of retinal vascular diseases, there can be a lot of different types of retinal vascular diseases that can be potentially treated. Okay, so the retina. This is actually my eye, remarkably healthy. If you cut it across in cross-section, what you see is a cross-section of the retina. And as I said, it looks like a cherry pie filled with lots of different types of neurons. These neurons have to connect up in very special ways to allow us to see. And all of the processing of light information occurs in the retina. Now, there are at least two areas where you have blood vessels. There are blood vessels that sit on the surface of the retina, and you can see them if you look inside the eye with an ophthalmoscope. You see the blood vessels coming out of the optic nerve, fanning across the retina. These are the blood vessels that are affected in diabetic retinopathy, in end-stage diabetic retinopathy. So that's one form of fibrosis where the surface of the retina, right at the very top, can be affected if you get abnormal blood vessel growth. Now, the second layer of blood vessels is underneath the retina, outside the retina in the wall of the eyeball, and this is called the choroid. And these blood vessels are the ones that are affected, that are problematic in wet AMD. And so I'm going to talk about that particular condition today. So the mechanisms of fibrosis following a retinal vascular disease, either from blood vessels in the eye or from wet AMD, have some similarities and are currently treated in similar ways, targeting similar types of signalling mechanisms. But there are also some differences as well. Okay, so let's talk about blindness in this country. This obviously also represents the Western world and the United States and Europe. The largest cause of vision loss in our community is age-related macular degeneration. This is data from my collaborator Robin Geimer from the Centre for Eye Research, and you can see that around 48% of patients who are legally blind have AMD. There's also a very significant number who have diabetes and other retinal vascular diseases. That's probably another 10% of all cases of visual impairment. And then you've got a whole range of other types of diseases causing end-stage vision loss, including things like glaucoma. So fibrosis...
Cataracts and glaucoma are still prominent in this?
This is probably because this is probably a little bit out of date. This is probably, and probably reflects some of those patients who would have been treated 20 years ago, where cataracts was not treated with an intraocular lens as it is today. So it's probably a little bit, still reflects some of that carryover. Glaucoma is still a major cause of blindness though, okay. So yes, maybe it's perhaps a little bit out of date, but it still reflects, I think, the proportions that we have in this country. Certainly AMD and diabetes is still a major problem, and as is some of the other glaucoma as well. So macular degeneration. Oh, these animations haven't come across. Okay, radio, no problem. All right, so what I was going to try and talk about here, what is the mechanism of AMD? What is the process? So there is wet AMD, there is dry AMD. These are two different types of conditions. Dry AMD is an atrophic disease that occurs with age, whereas wet AMD is a subset of patients. So patients who get older, they have changes in the back of the eye. 80% of them, 90% of those patients have dry AMD. But there's a subset, around 10% of all patients with AMD, that develop this wet AMD, and that is the blinding form of AMD, okay? So what happens? With age, we have changes in the back of the eye. There is a membrane right at the very back of the eye that separates the blood vessels from the retina. This thickens as we get older, and we have crud, a whole range of deposit that develops between the vasculature and the retina. So that thickening of that membrane and that crud that develops there causes a problem. It causes a problem in the way that nutrients and the essential vitamins, if you like, that are in the vasculature underneath the retina get into the retina. And this is crucial for the survival of the photoreceptors, the neurons that allow us to see light. So as a consequence of that, there's a little signal in the retina that says, I'm not happy, I need more oxygen. And that signal drives abnormal growth of blood vessels from the choroid into the retina, okay? So the problem of wet AMD is abnormal growth of blood vessels from the blood vessels under the retina into the retina. And it occurs in a place in our eye that is critical for central vision. So when I look at your faces, I'm using the part of the eye that's affected by macular degeneration. A tiny little bit of the retina that controls our ability to read and our ability to see faces, but it doesn't affect how we walk around. So these patients are effectively blind, but they still have their peripheral vision, which allows them to walk around and not drive, obviously. Okay, so wet AMD is this abnormal growth of blood vessels into the retina. And what happens if it's not treated is you get a scar forming, as you can see here, at that place in the retina, that very small place that controls central vision. It's very small, it's probably 0.5 millimetre in diameter, and it is critical for normal vision. It allows us to see high visual acuity, so high levels of detail, centrally, and allows us to see colour. So it's actually incredibly debilitating to lose that small bit of the retina. And patients in their 60s and 70s who develop this disease talk about, I can't see my grandchildren's faces. I can't see the next door neighbour across the fence. And these are the sorts of things that people talk about. The earliest symptoms are, as you can see here in this picture. This is a picture of the Eye and Ear Hospital, and you can see the very earliest change, and this is a very acute disease. It happens rapidly. But the very first thing that people notice is they sort of see waviness in their vision. So you close each eye, and one eye, they might look at something and there's lots of wavy lines. Instead of straight edges, it's all wavy. And that's because there's swelling already in the back of the eye. And then what happens? You get this whopping great big spot. And depending on how much bleeding there is at the back of the eye, this big black spot will be bigger or smaller. So it's incredibly rapid. This can happen within a week, a few days, or a couple of weeks. It's a very rapid process. Okay, so what's done? Well, there's been a constant development and improvement in treatment over the years. This is a picture of Robin doing a treatment now. The first medical treatments were developed in the early 2000s, and these involved, as you can see here in this picture, both these pictures here, an injection into the eye of a compound that blocks the abnormal growth of those blood vessels I mentioned a moment ago. And that is still the current treatment. So this current treatment is to block a molecule called vascular endothelial growth factor. Vascular endothelial growth factor is actually a growth factor we need to keep neurons alive. But if it's in too high an amount, it causes the abnormal growth of blood vessels. So the current treatments are targeting VEGF. And what happens is, and we've known this now since the early mid-2000s, the key clinical trials that showed that these compounds were efficacious were published in the New England Journal of Medicine in 2006. And the key thing is what's shown here in this red line. So there are three, at least two different types of treatments that target VEGF. One of them is Lucentis. Another one in the United States is called Avastin. They work exactly the same way. And then Eylea is the third one. But basically what these trials show, if you look at vision on the y-axis and duration of disease on the x-axis, what's shown here is under normal circumstances, if you don't treat the disease, you can see there's an unrelenting and rapid drop in vision to legal blindness and beyond over a 2-year period. If you now treat with one of these drugs that blocks the VEGF, you can see not only do you prevent vision loss, the line is not going down, but you actually improve your vision. Okay, and this is over a 2-year period. And so it has been a game changer. The treatments for VEGF came in 2006, give or take. This is shown here by the green arrow. So this is the incidence of blindness across the different years up to 2012. And you can see for AMD, which is this black line up the top, from 2006 onwards, you can see there's been a dramatic drop in the number of patients who go blind from this disease. It has been a game changer, and there's no other way to talk about it. It's fantastic. But here's a sting in the tail. Yes?
Excuse me. For an individual patient, what is the extent of recovery?
Aha, that's a very good point. Can I come back to that, if you don't mind, so we can talk about it later if I don't cover that properly? Because there is absolutely a sting in the tail. So it is a game changer. It is the current standard of treatment. You have signs of AMD. You get treated intravitreally with one of these anti-VEGF agents. In this country, it's Lucentis and Eylea, okay? All right, and for many of the patients, so we look again at those clinical trials published in 2006. Those clinical trials showed that for the majority of patients, you had that increase in vision when you were treated for 2 years. This is this graph here in red, okay, for 2 years, but around 25% of patients didn't respond at all, okay? That's what's shown in those clinical trials. Now, we know there are different types of wet AMD. There are types of AMD where blood vessels grow into the retina. There are types of wet AMD where the blood vessels are growing out of control, but they stay outside the retina. And there's another type where the blood vessels are actually growing abnormally in the retina. So the type that don't respond very well are those that actually grow into the retina. It's a certain type of wet AMD, and that's what was shown in this clinical trial.
Any biomarkers out there that are predictive of treatment success, or is that still coming?
Yes, actually there is. And that's because there are, when you see a patient, you look at their retina, as like the pictures I've shown you, you do fluorescein angiography to see where the leaky blood vessels are, but you also do a scan, it's a bit like an ultrasound if you like, of the retina. So you can see the structure of the retina crossways, like under a microscope if you like, in real time, in a living person. And that allows you to see how the different parts of the retina are affected in disease. Now, using that method, you can actually see sort of some, it's called subretinal hyperreflective material, and that is an indicator of poor prognosis. So you can actually diagnose these different types of AMD. Yes, and that's very important from a clinical trial point of view if you're designing clinical trials. Okay, so coming back to then the sting of the tail is, okay, so one, we have some people who don't respond to the current treatments, but they're treated nevertheless because there's nothing else available. Then if you look at the clinical trials and look at what happens now with the follow-up. So the initial clinical trials, which are shown here in grey, that was a 2-year clinical trial published in the New England Journal of Medicine and showed improvement of vision. Then what's happened is those same patients, 2,000 odd patients, whatever it was, have been followed now in another clinical trial for 2 years and in another one ending 7 years later. And this data was published in 2013. And what that showed was around half the patients who had the initial improvement in vision now are at the level of legal blindness. So in other words, we can stop the acute effects in most people. We can stop you going blind in that acute phase. But what we can't do is prevent you from going blind long term. If you live long enough, probably you're going to lose vision. And it's more than 50%. It's 50%, sorry. This is shown here in this paper here, and I've just taken out the title and the authors and highlighted the key phrase. 45% of patients had scarring or fibrosis after that 7-year period. So again, we can predict who's going to not respond, but we treat them anyway. But then in addition to that, you have this problem that people who do respond, half of those lose vision. You had a question, sir?
Does the scar development just appear in those Lucentis treated people or non-Lucentis treated people?
A scarring will, if you don't treat, you will go blind and it will be scarring, full stop,
So
okay?
it's the same type of scarring that comes later.
So there's two things. There's scar, if you don't treat, you get scar.
Yeah.
If you treat, most patients respond, but then over time, 50% or 45% develop a scar, okay? Then there's another group, that 25% who don't respond at all, they will develop scar. Does that make sense? So there's it's sort of a discussion of two different types of groups. Now, obviously, what does that tell you? That tells you we need alternative targets, and we need something that targets fibrosis and scarring that we can use in combination with VEGF. So there's two separate types of questions that need to be addressed. Did you have a question down somewhere? No, that's fine.
Do you think that normalisation of vasculature with anti-VEGF is contributing to the progression to blindness? Because, you know, in cancer therapy, there's a belief that using anti-VEGF actually allows for better penetration of chemotherapeutic agents, for instance, that give you a better cancer response. So in this situation, are you improving vasculature so that blood-borne cells, for instance, fibrocytes, for instance, may have a better ability to get where they need to go?
I think it's the reverse. I acknowledge what you're saying. I think it's an interesting point. I actually think what the VEGF is doing is it's preventing the abnormal growth and the leakiness of the blood vessels. Now that leakiness and abnormal growth is going to contribute to cells, immune cells, monocytes, macrophages and all those types of cells coming into the retina where they normally wouldn't sit. So normally the retina is, there's a barrier between the vasculature and the neural retina where you don't have any of those immune cells coming in. You have a break from the disease that allows that to come in. So I think I think when you're talking about the fibrosis here, I think it's actually to do with the fact that you've got that blood-retinal barrier breakdown. And what the studies have shown is that those patients who don't respond and those who have this problem 7 years down the track, these patients here, it's because they have got leakiness. They have got signs that the medication, if you like, is not working 100% the way you'd want it to work. And as a consequence of that, you've got this disease process going on. Does that answer your question?
Yeah.
So, yeah.
I think that's because they've escaped the control from the drug, like via VEGF-C, or that scarring has happened through some other...
There's a range of mechanisms by which it can occur. Part of it's because it's not just one molecule, one signalling pathway that contributes to angiogenesis. That's certainly absolutely one factor. And then secondly, there's probably some other disease processes to do with the cells coming into the retina and so on and so forth that contribute to the disease. Yes.
So, I mean, VEGF is only one of the things that contribute to angiogenesis
Correct.
in most parts of the body.
Correct.
There are other things going on.
Correct.
Have they been looked at with respect to eyes?
Yes, they have, but not in clinical trial, and I'll come back to that in a moment. Okay. But that's the clinical need is to try. There's a whole range of things that we need to do. One is, though, even though this has been a game changer, we have a treatment now where we never had one before. There's still a need to get new therapies. Okay, so when we talk about reducing vision with wet-AMD, obviously targeting the abnormal blood vessel growth. This basically means we do need to think about what is the mechanism of angiogenesis in the back of the eye, and are there other common pathways that we can target? And there's certainly some preclinical development in that area. Then there is also the fact that the blood vessels become very leaky and allow cells to come into the back of the eye which wouldn't normally sit there, and targeting those immune cells and fibrocytes, and CXCR4 is certainly one of those targets. And then we have the whole issue around tissue remodelling and scarring. And again, there are other targets targeting things like the TGF-beta pathway, for example, that could be of use there. So what we need to think about is what evidence is there for targeting each of these different stages and which ones would be of most benefit. So in terms of, just to summarise then what the drugs are in development, most of these are in preclinical development. So in terms of the clinical trials, what is out there is new ways of developing VEGF. new ways of just in terms of the way it's injected into the eye, so how it's delivered. But mostly we're still dealing with VEGF. What's out there preclinically is what you see in the slide. And you'll notice that some of these compounds have probably been talked about already in lung fibrosis and in kidneys. So basically, it's a recognition that angiogenesis is very complicated and there are a whole range of different pathways that are involved. So platelet-derived growth factor receptor has been looked at, integrins, which obviously are important in blood vessel growth into the back of the eye, angiopoietin, which is... There's certainly a lot of other information in terms of prevention of disease as well, where the complement inhibitors are certainly being investigated very heavily. So if you can prevent inflammation, that's thought to prevent some of the progression to disease. And then, of course, connective tissue growth factor, which is obviously a major fibrosis inhibitor, has been also trialled. Now, I should point out that these treatments here are obviously being developed on the back of a whole range of other diseases, and it's piggybacking into the eye. And I think that's been the case for fibrotic retinal disease, absolutely. In terms of diabetic retinopathy, for example, you treat with, if you can find a treatment for kidney disease in diabetes, you can usually use that to look at whether there's a potential for treatment in retinopathy as well. And likewise, for angiogenic disease, anything where you've got the same thing happening in the eye, you can use those same drugs. So this list would also be used for any of the angiogenesis and fibrosis that occurs following vein occlusions in the eye, potentially for some of the diabetic retinopathy. And it's end-stage disease I'm talking about when we talk about fibrosis. So diabetic retinopathy is a very common cause of vision loss, but the most common cause of vision loss actually is not the fibrosis part of it. That happens in patients who don't respond, who have very long-lasting type 1 disease, and it's where the blood vessels grow out of control and then you get retinal detachment. At that level, which is actually a relatively small percentage of the population, that's when some of these kind of compounds may be efficacious. And that's, so as I said, you can develop molecules for some forms of the disease and maybe it has carryover on other ones. Okay, so just to summarise then, so our interest, as I said, is in wet AMD. We have preclinical models, that's what we do. I collaborate with clinicians. Robin Geimer is the main one, who heads the macular unit at the Eye and Ear Hospital. So what we're looking at is whether, what are the mechanisms of the wet AMD in preclinical models, and looking at whether the various drugs and so forth are efficacious. And it is, fibrosis in the eye, I think, is a leading cause of blindness. I think it is something we need to look at for wet AMD. It's something relatively new. So in other words, it's only a recognition in the last few years that wet AMD needs to have co-treatments or alternative mechanisms. I think this is now becoming more widespreadly sort of recognised. But as well as that, retinal vascular diseases in terms of diabetic retinopathy also would benefit from some of these same targets. And of course, in terms of fibrosis, there's also the issue of surgical repair following retinal detachment. Now, retinal detachment is a problem. It occurs in about 1 in 10,000 people, particularly people who have high prescriptions. And the surgical repair can contribute to that fibrosis. However, the issue there is that surgery is still the treatment of choice in terms of repairing the fibrosis. And the question of what is the visual recovery following surgery versus no surgery and so forth is very difficult to ascertain. So again, if you develop something that is going to improve vision, it's probably going to have spillover effects and spillover opportunities in other diseases of the retina. As I mentioned, there's pretty much no treatments currently outside of the VEGF agents, and there is some commonality with some of the other forms of fibrosis around the body, such as the influx of immune cells. And so I think targets that are efficacious in lung or kidney may well have some benefit in the eye, if they are, for example, treated as a co-treatment with VEGF, or if they do have indeed some anti-angiogenic potential as well. So that's where we're working very closely with AdAlta because of the CXCR4 compound, and I think it certainly has had some very, very promising results in our animal models of disease, so our laser-induced wet AMD model that we use. And on that note, I'll open the floor to questions.
So how do you feel about your animal models? Do they faithfully replicate?
That's $1 million question.
Yeah.
So wet AMD, so macular degeneration, it's an age-related disease, and you can replicate different aspects of the disease in an animal model. You can't replicate the entire disease. First of all, rodents, which we use in the laboratory, don't have a macula, that very important part of the retina that's affected in macular degeneration. That's one difference. The second thing is no animal model of disease, whether it be a special mutant type of mouse, will go from having that dry form, those early age-related changes, all the way to wet AMD. It doesn't. So you can basically replicate the early signs of disease, the changes in the back of the eye with ageing. We have a number of models with that. And you can also replicate the abnormal growth of blood vessels from the choroid into the retina. And so I think the important thing to remember with animal models is you have to be very specific about the question you're asking. And once you've done that, then obviously get it into clinic as quickly as possible. There is no other model that's better. The primates, it's the same issue. You cannot use non-human primates to study macular degeneration. They get some of the age-related changes of early disease, but they do not go on to get the wet AMD in the same course that we get. So there are major differences there.
So given those limitations you just said, is it worth doing preclinical studies in several different models?
No, I don't believe so,
You don't think so?
because they're all broadly speaking the same. So the classic model of wet AMD is a laser-induced model, where you use an ophthalmic laser to burn, if you like, a little hole at the back of the eye, and by doing that you allow the abnormal growth of blood vessels from the back of the eye into the retina. Okay, so that's the classic model. Now, whether you do that on a mouse or a rat or a cat or a dog or whatever, I don't know, your choice of animal, it's going to be the same. So I don't believe that whether you do it in a rat or mouse, any model makes any difference. There are advantages of using mice because you can change the genes and probe the mechanisms a little bit in more detail. I should also point out there are some advantages too because it's relatively quick. So you get an answer within a week. So it's a 7-day experiment. I think that's valuable. But there's also a recognition that it's not true wet AMD in the sense that it's not an aged animal, and but I think it's still the best we have. Okay.
What is the systemic absorption of VEGF in intravitreal?
It's a very good question, and if you look at the clinical trials and what happens with patients, there is systemic absorption. You intravitreally inject the compounds into the eye, and there is some systemic absorption to the point where there is a risk of thrombosis with any of those types of treatments. That is absolutely the case. So yes, there is some absorption, and in all the clinical trials and in the clinical practice, that is certainly a concern that there is a risk of thrombosis and stroke in these patients. It's very low. I can't give you the exact percentages, but it would be very, very low regardless. So certainly intravitreal injection has its problems in the sense that there are complications, there's a risk of infection, there's a risk of developing cataract, there's the risk, all those things. But there's obviously advantages in terms of systemic absorption if you were to do it. You've got to do this every month or every 2 months for life. And so this is probably the best way to treat. There's no, in terms of delivery of drugs at the moment, unless you've got one that you can use topically, eye drops or something.
Those cells in the middle of the fibrosis, what are they and what are they laying down?
In the retina,
Yeah.
that's $1 million question because we know it's scarring. We know there's evidence for fibrocytes and immune cells coming into the back of the eye. But
Fibroblasts as well?
I don't believe that would be the case. It's a very difficult question because we do get some changes in fibrosis that do take on, for example, myofibrils. So there is a contractile component to it. But whether that's the same as what you get in scarring and in contraction in other areas of the body, I don't think it's exactly the same.
You get an increase in alpha smooth muscle actin within.
Yes, you do. But again, some of that comes about from cells that are not the same as you get in other sites. So that, for example, glial cells in the retina play a very critical role in that contractile property in the inner retina. In the outer retina, it's not really known. Okay, so
You can measure collagen deposition.
you can. Collagen 4, you certainly can. Yes, and TGF-beta pathways certainly.
Yeah, but I'm still not sure what's actually going on there. That's what I'm asking.
Yeah. So in terms of wet AMD, there's all of those. There's all of the pathways for TGF-beta and collagen and all those sorts of things are laid down. But I do think the cellular origin of that is going to be slightly different, perhaps, to some of the other areas of the body.
EMT?
I don't believe we've seen that. No.
Sorry, what did you ask?
EMT?
No.
So you don't believe in EMT?
I am a believer, but not in the eye.
Not in the eye.
Oh, okay.
Okay, we're dealing with a different type of cell. We're dealing with neurons and glial cells as well as, and there's no epithelium. Yeah.
With these surgical procedures involved in putting retinas back when they're detached, how quickly does the scar form? I mean,
It's over weeks. It's over weeks.
okay.
Okay, so what happens is, and maybe I showed it in the first picture, I can't remember, but basically the person who has a retinal detachment, where the retina separates from the back of the eye, this is usually fixed surgically, where they have effectively an elastic band placed around the retina, around their eye, and the eyeball's kind of squashed, and that forces the retina onto the back of the eye.
Yeah.
Okay, now over time that's followed, and if that doesn't take, you get fibrosis on the surface of the retina, which causes contraction. It causes the retina to shrink slightly, and that can then cause it to separate again from the back of the eye.
Right.
Now, if that is observed, and it happens in about 10% of all those cases, so it's about 8 to 10% of all cases of surgery in the retina, then there's different things that can happen. That's still the treatment of choice is to peel any membrane that develops on the surface of the retina. That seems to have the best visual outcome. But I should point out, with retinal detachment, normally the area that's detached, you wouldn't regain much vision there anyway. Okay, so that's why I'm saying it's actually difficult to, aside from making sure that the retina doesn't get any worse, so it doesn't completely detach off completely, that's really the major outcome with surgeries, to make sure it doesn't get any worse, okay, rather than recovering vision, if you like. Okay.
Going back to your laser-induced fibrosis model in the eye,
Yeah.
people do not transcript analysis over time course about what things have written.
We've done some transcript analysis using
Yeah.
PCR arrays to work out what pathways are involved,
So
and
do you get upregulation of various chemokines?
yes, of course, yeah, chemokines, absolutely, and also a whole range of different molecules within the TGF-beta pathway, absolutely. Yeah.
In some of the oncology models, CXCR2 drives a lot of the angiogenesis. Have you
Okay.
looked for CXCR2?
I personally haven't, but I'm sure that if I looked in the literature, I'm sure I would see some of that. Yeah, I mean, there's certainly, in terms of chemokines and inflammation, I mean, that's a very hot area, if you like, in wet AMD. The recognition that inflammation contributes to disease is well and truly well known. It's just a question of which chemokine am I going to target. So we've looked at
I can give you a list.
Oh yeah, don't worry. I'm sure you can.
We've seen other speakers give lists of targets in fibrosis in other indications. Given that you've said there are different cell types, is there any way you look at it and think, well, that rationally shouldn't work in the eye? Or
Shouldn't, no.
Or should?
Look, to be honest, I would like to see some more transcript analysis to be able to firmly establish that, to be honest. Because, at the moment, I think we're at an earlier stage than, say, lung disease or kidney disease in terms of fibrosis. So I want to do that before I would, put my money on it. But it's certainly, in terms of lung fibrosis and kidney fibrosis, there's certainly a lot of interest in looking at whether there's some potential for some of those treatments. And these are usually in the TGF-beta pathway. So the ones that we've been looking at are all in that kind of pathway, at different points in the pathway.